Um, Again, if you haven't already, and feel free to throw your name and where you're from in the chat. This is our first of hopefully many to come spotlights of different members in Region 3 within different subsectors of the emergency management industry. And so I do want to say thank you to Sarah, our Region 3 president, for helping organize this. She did a lot of background stuff on the tech and everything. Um, and then, of course, a thank you to Scott and Stephen for stepping up to kind of guinea pig this for us and be the first to do this webinar for us. They're both in the healthcare industry, part of our industry, and I don't want to give too much away because it's really about them spotlighting what they do. So we're going to start with Scott. If you do have questions, feel free to throw them in the chat. There's also Q&A spot. We will do Q&A at the end after they've both presented. And I also have some questions lined up to get the discussion started as well. So Scott, whenever you're ready.
Great. So good afternoon, everybody. My name is Scott Maynard. I am kind of in between positions, but I do start on Monday. I will be the manager of business continuity and emergency management for Centera Health System. Prior to that, I was the emergency management coordinator for Riverside Health System, which we oversaw 5 acute care hospitals, over 7 lifelong health facilities, as well as over 100 of the medical group facilities. Before that, I was the emergency management safety officer for Bon Secours at a single hospital. So my background came out after graduating from high school. I joined the Navy. I was a Navy diver, retired 20 years. And what really sparked my attention, I knew that I wanted to be a firefighter after the Navy. But while I was in the Navy, I responded to the bridge collapse of the I-35 bridge collapse up in St. Paul in Minneapolis, and doing the body recovery. But it was my first really true initial impression and the integration into emergency management of how everything kind of worked together. There was the Hennepin County sheriffs that were in charge of it. There were the Army Corps of Engineers, there were fire, police, and then military. But then you also had all the Red Cross facilities, hotels, and everybody else that was kind of like helping out and supporting us. And it really broadened my expectations of what emergency management was. As a firefighter paramedic, I started knowing that, hey, this is kind of like I need to move on. Started my master's degree in emergency management with American Military University. And it was probably one of my core classes that I took, and it talked about emergency management within healthcare, and which kind of baffled me. Never even thought of it. I always looked of emergency management as localities within the cities, jurisdictions, and then bigger picture federal FEMA kind of thing. Never even imagined healthcare. And it really sparked my attention knowing that I was a pre-hospital at being a paramedic. And I said, wow, this is just truly amazing. So luckily, the Eastern Virginia Healthcare Coalition, right at the peak of COVID, and they opened up a position for the resource management, which kind of opened the door for me to get into emergency management. I knew having the degree was the kind of a help, but having that skills and back set in emergency management would help me. So working with Coalition, I really was able to begin to work side by side with a lot of the healthcare systems, the hospitals, their emergency managers, dialysis, as well as lifelong or long-term care facilities, and meeting them and networking and understanding what they do. So again, luckily, Bon Secours had bought out the hospital out here in Southampton County in Virginia, and they hired for a safety officer, emergency manager, more for that emergency management position, which truly put me into where I am now. So I've gone from a single hospital emergency management coordinator to over 5 hospitals with lifelong health facilities, as well as medical groups. And now I'm about to venture to Centera Health System as being the manager of those different hospitals as well. So it's been a progression, looking at the areas to kind of help me along the way of achieving different certifications and education to build my knowledge, my background, but then also having that hands-on or the boots on the ground kind of thing for us, of knowing what to suspect, how to look at it, and encountering different, it's the old Hauser's approach that all the localities and state and federal use, but we also use it the same as the hospitals. I always say that the hospitals, EMs, we kind of get forgotten when the localities and the states are planning their exercises. They don't take into account or really don't think about it. And we try to understand that where you, as the emergency managers for those localities or states, yes, the emergency begins or the disaster incident begins with you, but ultimately it's going to kind of end with us at the hospital, because it is us that have to treat those patients that come, whether it's a hazmat, whether it's a radiation or a mass casualty shooting, et cetera. They're going to end up somehow one way or another with us. So it's the true integration that we're trying to formulate with our family assistance centers, the triaging, working with localities, the fire, the police, the rescue squads, to kind of build that relationship and that network that we need between everybody. Because at the end of the day, it's the patients that we care for. It's the same family members that you care for, but it's on a different aspect of looking at different things. And it's the being that paramedic, that pre-hospital care that I love. My wife is an emergency room nurse out here in Southampton, and I look at my job is to take care of those things, whether it's cybersecurity, active shooter, workplace violence, weather, et cetera, all those things that you plan for, but that I plan for the hospital, so that the nurses can concentrate truly on what their mission is, and that's to take care of the patients. So that way I can take care of the nurses and allow them to do their jobs. So that is, in a nutshell, what I do as an emergency manager for a healthcare system.
Thank you so much, Scott. I'll pass it over to Stephen, and then we can get into some Q&A.
Perfect. So thank you, Scott, and good afternoon, everybody. My name is Stephen Herring. I am what I'm called the local health emergency coordinator for the Virginia Department of Health down in our Crater Health District in Petersburg, Virginia. So we serve 8 different jurisdictions, 3 cities, and 5 localities. And within the Virginia Department of Health, I believe there's around over 30 different health districts, and each health district has a local health emergency coordinator who manages and runs their emergency management program on behalf of that district. And I'm more focused on the public health emergency management side of things. So to give you some background about myself, I have been in the emergency management field now for about going on 6 years full time. I started out at the local level, doing local level emergency management during my internship, moved over to higher education emergency management for a few months before going back to the local level. And what really drew me to emergency management was just that idea of helping people, especially helping people on their very worst day. And so I stayed at the local level from 2020 until 2022. So was at the local level during the height of the COVID pandemic. And then I moved over to the public health side of the emergency management operations. And what really drew me over to public health EM, one was I'm really happy that we have somebody on the line from that was a former USAID humanitarian, because at one point I wanted to go work for USAID and do humanitarian work, and the public health EM side of things really is what kind of aligned with my future career goals. But then there was also the bioterrorism side of things that really interested me, especially when I went into my master's program for public health and concentrated in global disaster management and looking at bioterrorism. We really focus a lot on bioterrorism at the public health side of emergency management. And at one point here at VDH in the mid to late 2000s, all we looked at was bioterrorism. And so that really drew me to it as well. Over in the public health side of emergency management, we're very similar. So same as what Scott said. We're very similar to our state and our local and our federal partners and our private sector partners. And we look at preventing, preparing, responding, and recovering from emergencies and disasters just from a public health lens. We take the same approach, which is that all hazards, whole community approach to planning, and making sure that we're doing that to build resiliency within our districts, within our communities to public health threats and emergencies. Uh, just really want to highlight that, we, as Scott mentioned, with the hospital system, we also prepare very, very much for a lot of the same threats and hazards that our local partners, our state partners, our tribal partners, a lot of the same threats and hazards they prepare for. We just look at it through a public health lens. And what do I mean by that? Let's take flooding, for example. From the local level, a lot of times is going to be looking at, hey, what can we do to try to remove debris, get people to stop driving through flooded roadways. So we're going to amplify those messages on behalf of our localities and our district. We're going to push that messaging out and amplify that messaging. Hey, don't drive through flooded water. Hey, stay clear of that area. But we're also going to do post-flooding surveillance to look for disease outbreaks. Was there any wastewater illnesses that are starting to break out due to that flooding, and we're going to be looking at that. We're going to be supporting community sheltering. Of course, when we think of large-scale community sheltering, we think of social services here in Virginia really managing that. But we also provide support through disease surveillance, food inspections, general volunteer support for registration and dormitory support. So we provide that public health support to mass care operations, including community sheltering. And then if we think of water utilities failures, we support those local operations through the provision of helping to provide water to residents who may not have it during that period of time. We're helping the localities distribute emergency water during that period of time. And we also look at active threat for our staff and for our facilities, workplace safety, workplace violence. We're also internally looking at those same threats and hazards as well, and how we can work to mitigate them, how we can work to build resiliency internally within our staff through training, through different measures to reduce any internal staff incidents that we might have to our facilities. Perhaps the biggest threat, though, that we look at, and this may not be a shock for many thinking back to COVID, is disease outbreaks. That is perhaps the biggest threat that we look at. And we are constantly working with our different public health staff to identify diseases that are occurring locally, regionally, across the state, nationally, globally, looking at, hey, what might be coming down the pipeline? Hey, do we have this disease that might be occurring somewhere over in Africa or somewhere over in South America or even across the nation? And we're starting to see that it's getting worse. Well, how could this impact us? What are the different routes that this could impact us? And do we need to start putting together preparedness plans for that specific disease, for that, how we're going to respond if we start seeing cases down here? So we really look from a preparedness standpoint at that aspect. We work with our epidemiologists, which is essentially our staff that does that disease surveillance, that disease investigations, to, okay, if we have any local outbreaks of diseases, whether they're within the community, whether they're within any type of long-term care facilities, schools, what have you, to mitigate those outbreaks, to provide the education, the resources, the PPE, what have you, that's needed to start mitigating and reducing cases so that way we don't end up with an endemic or an epidemic or another pandemic. We train our nurses, we train our public health staff on incident management processes and systems as such as the incident command system and point of distribution pod processes for mass vaccination. So that way, if we have to stand up pandemic or endemic or epidemic level operations, our staff are trained and ready to go to be able to stand up those clinics and provide those resources. And we also conduct routine exercises to test those mass vaccination clinics. Here in Virginia, we are required to do an annual flu vaccine clinic every single year, which is essentially an exercise of our mass vaccination plan. How do we provide mass vaccinations to community members if we have to on a large scale basis, and we are required to do that every single year. We also, as I mentioned earlier, we look at bioterrorism. We also look at chemical, biological, radiological, nuclear, and explosive hazards. So we work very frequently with the Centers for Disease Control and Prevention, or the CDC, to ensure we have what's called the CHEMPACT program, which is essentially a fancy way of saying every district has a big box that is within a certain hospital or within a certain EMS provider in that district, and that is medication that would be utilized in the event that there is some sort of nerve agent attack. We work with those cache sites, was what they're called, to do routine inspections of those chem packs, put together plans for utilization of those chem packs, and exercise those plans. So that way, if there is a nerve agent attack, there is clear plans and processes for activating that chem pack, utilizing the medication, and reducing the hazard. We also, here in my district, we also have a nuclear power station. So we have a very, very big role in the distribution of potassium iodide, or Ki, in the event that we have some sort of radiological leak from that nuclear power station. We're involved in exercising how we do the distribution of that Ki, working with the jurisdiction to put those plans together. Now, while we are to ensure that we're planning and preparing for these threats and hazards that might impact public health, we do take, like I said earlier, that whole community approach to planning. We have our communications plans. We have mass care plans that look at sheltering, emergency distribution of supplies, family assistance operations. We have the THIRAs, the continuity of operations plans, the emergency operations plans, to guide us through those emergencies. But we also have plans specific to public health that work for that disease outbreak, the disease management side of things. So we have epidemiological response plans that really look at, hey, if we start seeing disease outbreaks in the community, how are we going to set up a team to start managing those different outbreaks and start mitigating the impacts from them? We have mass vaccination plans and mass medication dispensing plans to be able to vaccinate and provide medication on a large whole community scale if we start seeing large scale outbreaks towards an epidemic or worse level. Here in Virginia, we are required to go through what's called Project Public Health Ready through the National Association of the City and County Health Officials, or NACHO. And essentially, it's this huge process that requires each district to submit detailed emergency plans for hazards, their exercise plans, documentation that they've gone through a response. It essentially is a sort of accreditation program that highlights that, hey, these districts, these public health emergency management offices are prepared. They have the resources, they have the plans, they have the expertise to be able to manage public health emergencies on a large scale. And it is something Virginia, I believe, is one of the only states that require each one of its health districts to go through this process. We also have volunteer capabilities within the district. You may have heard at the local level, the community emergency response teams, those volunteer cadres of local residents who are trained and ready to support each other and the jurisdiction after a disaster if they're called upon. At the public health side, we have what's called the Medical Reserve Corps. They consist of both medical and non-medically trained volunteer, and they do act, once again, same thing as certain and other volunteer programs, as that force multiplier to help in both blue sky and gray sky days. Some of our medical volunteers can be nurses, it can be doctors that can assist during emergencies that require, let's say, mass vaccination, mass medication dispensing. If you saw during COVID, a lot of MRC volunteers were utilized day in and day out during those pod clinics for mass vaccination and mass testing, and we would do that for other disease outbreaks and emergencies requiring a medical trained person. We would utilize those volunteers as well. We work constantly to make sure that those volunteers are trained, that they are capable, and they can assist to be able to provide support during emergency operations if we need to call upon them. We also have what's called the Hospital Preparedness Program through the Virginia Department of Health here in Virginia, and that is through the Administration for Strategic Preparedness and Response, or ASPR. That is used to build and grow healthcare coalitions. Then those coalitions can include memberships from hospitals, public health, EMS, local emergency management, state emergency management. And really what it does is it helps bring all of those public health, those healthcare partners, those emergency support aid function partners together to the table to allow for better coordination, better communication, better collaboration. And then through that, here in Virginia, we have the Virginia Healthcare Alerting and Status System, which is essentially, hey, how do our hospitals provide status updates? How do our public health provide status updates? And how can we view what those status updates are? If we think back to the air crash collision at Reagan National Airport, VHAS was used very frequently to be able to provide status updates between partners during the response operation. We also work with different other partners. As Scott mentioned, at the hospital, we really try very hard to work with the hospital through our healthcare coalitions to support and coordinate with them regarding any impacts they might have to their facilities, as well as working together with trainings and exercises. We work with our colleagues at the state level emergency management office. So even though here in Virginia, we are a state office through the Virginia Department of Health, we work with our state emergency management office to make sure that we're sharing plans, sharing information, sharing exercises, getting involved and observing and being part of each other's exercises so that way we're building interoperability between one another. And because we also, our districts consist of multiple localities, we have to work very hard with our local partners to mitigate any disease outbreaks and support disaster operations that they might be going through when needed from that public health lens. We also might include and interact with law enforcement, fire and EMS, social services, mental health, and other private industries, to name a few on a very day-to-day basis. Uh, and there are a few areas of Virginia within the public health side of things that interact with key partners that other areas won't. And let's take, for example, our national capital region. They work very heavily with ASPR, with CDC. Dulles International Airport is currently the port of entry for any highly infectious person who might be bringing disease over from out of the country into the United States, so that way they can receive treatment, they can receive monitoring. So that's actually through Dulles. And so our Northern Public Health Emergency management partners work very closely with Dulles, with the CDC, with Health and Human Services to train and to exercise those different types of plans with Dulles to make sure that we are tracking, we're monitoring, and we're able to provide treatment to those individuals as they're coming in. We also work with local businesses and key stakeholders to foster and promote community organizations active in disaster. So taking that VOAD concept, those volunteer active in disaster concept, and bringing it down to the community level to foster that community resiliency. Uh, we also have finally community health workers at the public health side, and that's not necessarily within our EM office, but that's once again sort of like that force multiplier. And what a lot of our districts, what a lot of our public health and emergency management partners here in Virginia have started doing is utilizing those community health workers during large scale disasters to work and be side by side with our disaster survivors as they navigate through the recovery process. Now, these community health workers, they have connections to key partners and key services, especially those that might be activated during disaster declarations. And so those community health workers are then able to walk and support these disaster survivors through the recovery process and then connect them with those key services and those key support operations as those survivors are working through the recovery process and helping them on their worst day. So that's all to say. All that's a lot of information just to say that from the public health side of things, we're very similar to some of our local, to our state, and other private partners, our tribal partners, but we definitely take sort of a public health flavor to our emergency management operations and definitely look at things from a different lens.
Dang, Stephen, that was a lot. I love it. I love it. Thank you again to both Stephen and Scott. I would like to open the floor to our attendees to shoot a question. It can be for either of them or both of them or one or the other. Does anyone have any questions? Sarah. I see you unmuted, Sarah, but we can't hear you. If you want, Sarah, you're more than welcome to put the question in the chat. Okay, no problem.
I think we were all muted initially.
We were. Okay, wait. So now I think we can hear you. We could hear you for a second. Okay. We will look to the chat for your question. Oh, the anticipation is killing me. All right. I've seen a lot of certifications from FEMA on job postings. Do most folks have these when they already apply, or do they get them on the job? Perhaps it differs by role and organization. It looks like she is going to be typing another question, but do you guys want to take that at all? I can talk to certifications too.
Sure. So the way that I looked at it was, yes, it's nice. There are tons of certifications. There's the ones for FEMA independent study. You can go to the college. You can look at CDP. There's Homeland Security ones. I mean, there's TEACs. There's a mass variety of places out there that does the certifications. And I mean, truly, it helps, yes, one on your resume, but also it gives you that expanding knowledge on certain areas that you want to look into, whether it is chemical, biological, radio, nuclear explosions, if it's on cybersecurity, on whatever it is, debris pickup. But I mean, there's tons of out there. And truly, when you look at them, it does help expand and broaden your knowledge on different areas. I mean, they're not mandatory. I mean, you can know that what is it, 1, 2, 7, and 800 for FEMA. That's the basic on really anything to continue on taking. I know TEACS offers, if you take certain classes, you get certifications within it. FEMA does the professional development system. There's the advanced development, executive. So it all depends on really what your flavor is. It's kind of like Baskin Robbins. You know, there's 31 flavors. You can go and take tons of courses, but truly it's upon you of what you want to help you out. Yes, they do help build that knowledge in a lot of the jobs that are out there today, or whether it's local, community, or local, state, federal, even within healthcare systems. They like to have those things seen. But it does build for, if you're looking for your certified emergency manager or through the Virginia professional emergency management, all those courses add on to it. They're required to have certain areas and time within it.
Thank you,
Yeah.
Scott. Stephen,
Yeah,
you didn't have
I would
anything?
I would just piggyback off of Scott. You know, I think that, you know, there's, as Scott mentioned, there's so many things out there. It definitely is up to like your flavor of where you would want to go, what your thought process is. You know, I know that when I entered the field, it was, as Scott mentioned, you have the basics like FEMA IS 100, 200, 700, 800, and, you know, I'd say that'd be almost standard for any entry level position, is just having those underneath your belt. But then as you get in and you start working through the process and start working through where you want to go, it's all about where you want to land up. Do you want to do continuity of operations? Great, there's a training track for that. Do you want to do exercise and trainings? Great, there's a training track for that. Do you just want to do like the all around emergency management operational standpoint? Great, there's the emergency management academies. And there's also those additional courses, as he mentioned, through TEACS, through CDP, Centers for Domestic Preparedness, etc., that are all available. So as far as having them when applying, you know, the basics such as 100, 200, 700, 800, you know, I always recommend, you know, having, you know, those underneath your belt. But other than that, you know, it's just trying to maneuvering as you go along.
And I will just add, I mean, they pretty much covered it all, but I look at your job description, and some of them will say you can get them within the time. It really depends on what the job is. 300, 400, also, especially if you're going into response-oriented things, positions. I see you have a second question here, Sarah. Do you have any tips or recommendations for USAID folks who worked international humanitarian operations thinking about pivoting to domestic response?
Again, I would have to say, like Stephen was saying, it depends on where you want to rotate into. Is it local, state? I mean, they're kind of looking at the same branch, you know, healthcare as that what we are in. You know, there are different categories to look at too, or different courses that would help you be more successful in achieving. There are different certifications out there through other than the like FEMA, CDP, DHS. You can get your certified health emergency professional, et cetera. It just depends on where you want to rotate coming from back into the States.
Yeah, and I'll also add, as I mentioned in my brief overview, when I went into the public health side of things, at one point in time, I had, looked at USAID as a future career goal, and then looking at what the work that you all did at USAID and, identifying what experience I needed. That's where I aligned closely with public health EM. So, I would say, I believe you put in the chat earlier, you live in Washington, D.C., and there's a lot of great connections in public health EM in the Maryland, Washington, D.C. area. And making those connections, if you're wanting to try to get into the field, there's a lot of great connections up in, both at the local level, the healthcare level, the federal level, the state level. There's a lot of great connections, a lot of great people, and having those networks, reaching out via LinkedIn and establishing those networks now, I think would be one of the top things to do, especially if you're looking to pivot back to domestic response and planning. Is going ahead and getting your name out there, going ahead and on LinkedIn, reaching out, saying, hey, can I talk to you a little bit more about what you're doing? Or hey, I see you have this position open in your office. Can I ask you a few questions about that? And going ahead and getting your name out there. And I'd be happy. I can put my email in the chat, and I'd be happy to connect you with some few individuals up that way that I know of that might be able to help you out.
Sarah, can I ask, are you an IAEM member? No, okay. So I would say look to wherever your state, it's okay. Wherever you're like living, most states have state associations. I think most people on this call, if not everyone, is from Virginia. There might be some other folks from not Virginia, but and then IAEM is obviously international, but we do have a USA chapter. And there are many levels of membership, including those who are like early professionals. I think it's, I want to say $100 for folks who are like not yet in the industry but want to join or whatever. There are caucuses for like literally pretty much every part of our industry, including healthcare and things like that. And so go look at the website. We are always recruiting new members. We have a national conference that's usually October or November. This year it's going to be in Kentucky in November. I don't know the exact dates, but that's also a great place to go to network and just learn. They have a lot of trainings and things like that. And there's opportunity to volunteer to work off the cost of the conference as well. And so I definitely, if you want to talk at all about any of the resources that IAM can provide, please feel free to contact me. I'll put my information, my email's right there on my little box, but I have been in managing membership for the last couple years, and so I hopefully could answer most, if not all, of your questions. So that's for anyone else who's on the call who isn't a current IAM member. This was open to everyone, and we're glad that you are here. I give 15 seconds to see if anyone else has any other questions in the chat, and then I have a few of my own as well.
I raised my hand. This is Francis, formerly with USAID's Bureau of Humanitarian Assistance. And I have to ask, the most obvious question is like, what now being a former, worker for the government, what are you guys seeing and hearing on your end too? Because there's obviously a lot of other changes that are predicted to happen for government employees.
And I will say this answer is going to be different for both of them because one of them is private and one of them is a government worker as well. So I don't know who wants to take this first. We're all being impacted, of course, but there's different levels of impact. So
Stephen, I'll let you take this one since we were just talking about this.
Yeah. So first, thank you for the question. And thank you for the honest question, because you're absolutely right. That's definitely the big thing in the room. We are seeing impacts. We are starting, we are we're starting to see some of the grants that we utilize within our public health departments be cut and be terminated. Not within the public health EM side of things, but from within the public health departments in general. What the future will hold, though, we're the information is coming to us, as I'm pretty sure it did with you guys, very last minute, and so we're just kind of monitoring at this point in time. I would do want to be upfront and say that within Virginia, from the public health EM side of things, we are grant funded. So I do want to just mention that up front. However, at this time, we're not seeing, nor are we have been notified to expect to see any impacts as of yet. But other operations are being impacted, and it is definitely something that we are all continuing to monitor, to be ahead of the curve, so to speak.
Scott, any comments?
Yeah. So as a nonprofit healthcare system, the way that we operate, we try to, within emergency management, we try to correlate and conduct our operations with the Healthcare Coalition, our Eastern Virginia Healthcare Coalition, and their grants really do play a big thing. So the grants that they see, that we see, come from HHS to ASPR to VDH down to us, and it allows us every year. The coalition is provided X amount of money. And it has to meet within what their operations are and commitments and their goals that ASPR has set out down to VDH. So over the past years, we've been able to utilize these grants to purchase decon tents, new PAPRs, which is our breathing air systems for the nurses and health systems, to boots, to chemical suits, to tents, etc. So we do see a lot of it. Has it affected us yet? No. But again, we don't know where this new budget year come July will affect us.
And Francis, I don't know if you're a member of IAEM or of your local state associations, but definitely if you're looking into coming into this side of the industry, obviously you all worked internationally, really more or less in this industry. So there are a lot of opportunities. But I know Virginia has a job board, IAEM has a job board. As much as jobs are being cut, unfortunately, there are jobs being posted. And so, like, I know Scott's new job was recently posted, things like that. We have one in Richmond for continuity of operations, things like that. So all hope is not lost, but it is obviously a time of struggle for our industry. I thought you were in Colorado. So Colorado does have a great state association. So if you haven't had a chance to look into that, please do so. And then, of course, IAM is, I would say, is probably more robust than any state association just because of what it is. And if you're open to moving, there's a lot of things up there. But again, being able to go and see the caucuses and kind of learn the other parts of the industry that aren't the international side. A lot of opportunity there, and then that just helps you network if you're able to go to meetings. And with the International Association, most, if not all, meetings are virtual, which is nice. Any other burning questions? Otherwise, I've got a couple as well, but please feel free to keep asking questions as the conversation continues and throwing them in the chat as well. Okay, cool. So this is really awesome. I'm glad that we were able to do this and have this conversation. So can you guys touch on maybe how technology plays a role, AI, different softwares, different systems that you're like, I had to learn this and it wasn't something I was familiar with, or things that you're excited in regards to technology moving forward?
Sure, I'll go ahead if you don't mind, Stephen.
Yeah.
So my biggest thing is, and I say this because COVID, was it horrible? Yes. But the best thing about it that we brought out of it within a healthcare system wise was no longer having to be in person to open up our emergency operations center. again, everywhere now we're starting to do a lot more things virtually using either Teams or Zooms. Those means to have our initial assessment team kind of come together, deciding on how the incident or disaster could affect, could affect the health system. Do we need to stand it up? Do we need to operate a little bit farther? But it's been amazing utilizing Zoom and Teams, I have to say, in my opinion. But other technologies that's come about, I love writing exercises. I love doing games for our healthcare system, our nurses, and using AI now has been amazing, especially going into request different patient triage cards on their initial assessments over time. It saves me trouble of having to think, okay, hey, if this person was severe diabetic kind of thing, what is their vital signs going to initially be? What is it going to be 7 days later, et cetera? So utilizing AI coming about, especially for pictures too, it really helps. You just have to be very specific. I have to say those are the two biggest programs that I've enjoyed that have come about since COVID and utilizing up to this point now.
Perfect. At my side of the public sector, at the public health side, at state government, we are, as Scott mentioned, we predominantly do a lot of things virtually now. I'd say the past few years, almost all of our operations have been virtual when we go to emergency operations, such as setting up our EOC, et cetera. We are trying to get a little bit more back in person, just so that way people don't lose the experience of having to activate in person if necessary. But we do have that capability now, as Scott mentioned, to really stand up operations and do things in a virtual manner, which we utilize most of the time. In fact, we did it a couple weeks ago and a few months ago during the snowstorms earlier this year. When it comes to AI and like ArcGIS and stuff like that, we have access to it because we are state government. There is a lengthy process to be able to get it, even though, let's say, for example, ChatGPT and AI is public facing. I can get online and use it. I can't do it through the state system unless I get prior authorization. And there's quite a process to be able to get authorization before I can utilize anything like that. And those are all mandated in state code. So, while we really strive to use more innovative technology, we sometimes are not able to use it as fast as some of our other partners, such as Scott, or our partners at the local level, just because there is quite a process we have to go through before we can get access to it. And then there is the learning piece that comes along with it.
Course. I know I have sirens on my campus, and it's something that I have had to be in charge of, and it's been an ongoing battle of the company has a person for every little aspect of the software, except for I'm supposed to know all of them, even though they have 20 different people. So that's been interesting. So technology is it's great, but it's terrible.
Very true.
Yeah.
It's good when it works. All right. So outside of COVID, which I know affected everyone, can you talk about maybe something that we wouldn't have thought of in terms of an emergency that you've dealt with maybe in the last 2 to 3 years?
Absolutely. First, because I know we had a member that just had to recently hop off. So if there's anybody that does need to leave early and y'all want to follow up for questions, I'll put my email in the chat, and you're more than welcome to reach out and find me on LinkedIn. I'd be happy to answer any questions outside of here if you have it afterwards. I would say the biggest one outside of COVID, but it's also going to be unfortunately a disease-focused one that we may not have thought of a few years ago, was Mpox. Back, it was at the tail end of the pandemic phase of COVID in 2022. We started seeing outbreaks globally of Mpox. And then it filtered. We started seeing them down in Virginia, and we started seeing local cases and having to maneuver through that, including despite all the experience with COVID, because this was a completely different disease with completely different how it could people could get exposed, et cetera. We still had to set up and develop specific procedures for how we managed that. And that was not something that people, even our epidemiologists expected to see. even during COVID was, this disease that while it's been around for so long, this new, what we were seeing then was not very common to what it would look like previously. And so having that ended up being a good, 3 to 6 month response. And that was definitely something that was not on our bingo card, so to speak, previously.
Yes, for us, it's kind of a two situations. The biggest one, I mean, that I'm sure everyone is very aware of is workplace violence within the healthcare system. It has drastically increased that our nurses are being either bullied, yelled at, abused, shot. I mean, you saw what happened up in Pitt not long ago. So it's one of those situations that you're seeing after post-COVID. There are so many behavioral issues, and the biggest thing is that there are not enough facilities to house these patients. So you're having these behavioral patients sitting in the ED, having a one-on-one with them until they can find somewhere permanently for them. The second one, of course, is our fentanyl, and it's again another one that has rised drastically within the area coming in, and it's not so much being sent in, but it's being processed in the homes, facilities, the kind of pre-made stuff, and the pills with the pill press that are being pushed out, you really don't know the amount of fentanyl that each person is receiving. And that was our biggest concern last year. We actually conducted one of our function or full-scale exercise with our community partners of doing a hazmat drill on a fentanyl exposure to where it was gang related. Fentanyl got exposed into the air, and then we started bringing in not just the patients that were exposed to it, but also the first responders that ended up having to get exposed to it because they didn't know what was going on. So I would say those are our two biggest post-COVID exercises or events that we're seeing within the hospital system.
Yeah, and I just actually want to piggyback because Scott, you brought up a good point that it slipped my mind was the fentanyl piece, and there was a specific piece of because we work very heavily with the overdose crisis. We do naloxone training, etc. But there was one piece last year that it kind of shocked us from a standpoint. I mentioned earlier about the bioterrorism piece of ours and how previously these positions were really focused on bioterrorism, specifically after the 2001 anthrax attacks. Last year, we started receiving requests from a lot of our registrar's offices and elections offices say, hey, can you all train us on naloxone? And what we started realizing is that there was a fear within the elections offices based off of some incidents that happened during the 2023 election where people were mailing in fentanyl similar to how similar to the 2001 anthrax attacks. And then the fentanyl they were getting exposed to the fentanyl and overdosing. And so it was almost like a new form of bioterrorism that we were seeing. And so it was definitely a different it was a different view of what we were seeing with fentanyl and how it could be used for very nefarious purposes that we then had to start identifying and working through how would we handle this and how can we get this training out here to our registrars, to our election offices, based off of this threat that was here before, but now being utilized in a more nefarious fashion.
Thank you, guys. It's always, the different communicably spread things. It's very interesting. I know we are also seeing measles, and we've seen possible cases of mumps on our campus and things like that. So I appreciate all the work that you guys do in educating the rest of us when those things pop up. So I had a list of questions, but you guys have actually just done such a good job telling us all about your sides of the industry, and so we've answered a lot of them. I guess with the last 10 minutes here, any final notes? Some of the areas that we've talked about are future trends, career growth, training and development, both for your partners as well as yourself in career growth, community involvement. I know, Stephen, you touched a lot about your partners in public health and how anyone can kind of get involved. Scott, I don't know if you have any thoughts on that from the private side. Talked about collaborations, technology, different skills your general responsibilities and how you got here. So we touched a lot of great things today. So final thoughts, if there's anything from those categories or anything else that you feel that you want to talk about in these last few minutes.
I guess my biggest takeaway is to never forget about your hospital systems. Some way, in form or another, the incident's going to end up at the hospital. We need to partner with our higher education for shooting at the colleges, or if you have shipyards or bases, major industries, it's some way, form or another. Like I said, they're going to come back here. But then the biggest thing is also working with us so we can work with you is for the families. They're going to want to know where their kids are, and it's going to be overwhelming. I mean, you look at within just the Hampton Roads area of Virginia, between Centera Health System, Bon Secours, Chesapeake Regional, and Riverside, there are a vast amount of hospitals, and your family member could be taken to any one of those. And so trying to utilize the systems that you have within your localities for us in Virginia, we have 211. We use a Virginia hospital alerting system where we can communicate what patients, victims, where they're at. 211 can reach out utilizing family assistance centers. But within exercises, whether it's for your locality, et cetera, or for us that we reach out to you, utilizing y'all, it's very important. And just don't forget about us. The health system, it's there.
Perfect. I want to touch on two quick things. First, as Scott mentioned, same thing, don't forget about public health. I think COVID really showed how important the emergency management within public health is and how it really needs to be integrated within the local, the hospital levels, the state levels, etc. And so make sure that you're touching base with your public health emergency managers. Don't let them live in a silo. Sometimes at the public health level, it can be silo creation can get very easy. So don't let them live in a silo. Bring them to your trainings, bring them to your exercises. Make sure that you're communicating with them and that they're communicating with you, and making sure that, hey, don't just rely on public health to create the pandemic plans. Ask about them, like, hey, what would we do? What is your thought process for how we would in this jurisdiction operate for a pandemic? Go ahead and start that conversation, because it's definitely a whole community approach. At the public health level, while we create the plans, we do really rely on that community partnership to enact those plans, especially if we're talking about mass vaccination, because we don't have the staff, especially for some of our districts, to do it in each jurisdiction in tandem. So we definitely rely on those community partnerships. So don't forget about us. The last thing I want to say, and this is specifically because I know we have a few of our members are from or are here trying to learn more about how they can maybe get integrated more into domestic emergency management. Network with those around you. We always like to say, in all aspects of emergency management, it's not only about what you know, it's a lot about who you know. So network with those around you and ask questions, get information, and that might lead to another connection, which might lead to another connection, which might lead to a potential opportunity somewhere. So reach out, make that first step. Francis, I saw your connection. Thank you. I'll make sure I add you. And just make sure that you're putting yourself out there, because it can really benefit you in the long run. And if you have any questions, please utilize all of us to ask any questions you might have. Maribel gave some great resources from the IAEM perspective, and utilize those resources to help you along the way.
Sorry, one last thing to follow on with Stephen. Like I tell everybody within our healthcare system, we as emergency managers, it's not just healthcare, but emergency manager, we play in everybody's sandbox. We don't own a lot of the stuff, but we definitely collaborate, we network, and that's what keeps it going. And it's those networks that you build, that bond that you build with someone. You never know when that things hits the fan or that incident happens, that you're going to need to call upon somebody that you like, I am so glad I made that connection down the road prior to when the incident happened. So again, reach out, make those connections. Like Stephen said, it's very important.
Thank you guys so much. We are about done with our hour. So again, Stephen, Scott, couldn't do this without you. So thank you so much for being our first webinar. To those who have joined us today, thank you so much. We hope that you will continue to come to these webinars. We're going to try to do them at least once a month and spotlight different sectors of the emergency management industry. And I think it goes out saying, but feel free, Sarah, our Region 3 president, Scott, Stephen, and myself, we do these because we want to share information. And so please find us on LinkedIn. We're here to answer questions. We love making our family bigger. And Sarah, I'll let you have a final note as well.
I wasn't planning on saying anything, but Maribel does such a great job. So I just wanted to, let her run this, and she, she and our speakers did a great job, as I fully expected. But please, as she mentioned, reach out to me, reach out to other IAEM members. We are more than happy to help. Focus on your state associations as well. The job boards are a great use for both organizations, for the states and for IAEM. But more than anything, we just love hearing from IAM members or potential IAM members. So just please stay connected. Glad to see that there's already been a connection made on LinkedIn. So thank you everybody for attending today. Really appreciate it. And Maribel, I'll turn it over to you for final comments.
Awesome. Yeah, for our attendees and for our speakers, we're going to do probably at least really just one email as a follow-up, maybe have a couple survey questions in there asking if you have any follow-up questions for our speakers, if there are any other sectors that you would like to see, if you have any folks that you think would be good presenters that are interested in sharing their stories in their sector. And that's pretty much it. So I hope you all have a good Thursday. Sarah and speakers, if you want to stay on for a quick after action, if you have a moment. And then everyone else, you're free to go. So thanks for joining us today.
Thank you, everyone.
Thank you, everybody.
Thank you.